us here in the AHIP office in just a couple of minutes, so he'll be here shortly.
Okay, that's great. I know Lori's going to be calling in shortly. She's a little late. Sherry? Is Sherry on? Jay is on. Doreen? I don't think I've heard. Crystal is on. And have we heard Diane?
Charles, Doreen is on.
Perfect. Okay. My apologies. Is Pam Jodock on? Okay. John Kelly is not. Is John Klimek on?
Yes, I am. Good morning.
Good morning, John. Heather's on. Tim McMullen. Rob Otten is on. I'm on. Leanne Simmer is on. And the replacement, this is a good time to announce that, is Walter Schwartz, which we all know, is taking the place of Chuck Jaffe representing HL7. And that occurred just a week or so ago. So he'll be joining us in the future, but it was too soon for him to join this meeting. So with that, if I missed anyone, let me know. If I didn't, certainly if we have any people joining in the interim, please raise your hand and make a noise. With that, I want to thank everyone. This is a great turnout after a nice weekend that I'm sure everyone got their amounts of food and maybe even the shopping stuff. But certainly we welcome you to the PA Council. Today we have, I believe that Crystal, you're going to be presenting for the Cooperative Exchange. We have the Weedy Prioritization Work Group presenting, and we have AHIP, and we have BCBSA presenting. And then on the 4th, at our meeting that's face-to-face in Reston, we have the remaining organizations that will be presenting. With that, Crystal, if since I understand that, would you like to begin the presentation, and would you want to share your slides if there are slides?
Sure. Do you want to just give me presenter rights, and then I can send them out after the meeting?
I can do that. Please, how do I do? Yes, I just have to know what I'm doing.
Okay. I'm there. Can everybody see my screen?
It's showing.
Okay. All right. Well, good morning, everyone. My name is Crystal Ewing. I am a board member with the Cooperative Exchange, representing the National Clearinghouse Association. I'm also the manager of data integrity with Zermit. On with me today, I do have Doreen Espinoza, also from the Cooperative Exchange. So just a little bit about a clearinghouse for anyone on the phone that is not familiar with the clearinghouse industry. Clearinghouses provide a single point of contact for providers and even payers, allowing them to exchange transactions while maintaining connectivity with very few sources. Providers do not want, nor sometimes have the resources to establish and maintain connectivity with a large number of payers that they send and receive numerous transactions. And in turn, payers do not want to maintain connections for every provider that they exchange transactions. The Cooperative Exchange is a nationally recognized resource and representative of the clearinghouse industry. for the media, government bodies, and other interested parties. We have 26 member organizations that represent over 90% of the clearinghouse industry, over 75,000 submitting provider organizations. We maintain over 8,000 payer connections and 1,000 plus HIT vendor connections. We process over $4 billion in claims annually, valued at over $1 trillion. And the Cooperative Exchange truly represents that healthcare EDI highway infrastructure across all lines of business in the country. So a little bit about our members. This is a list of our member organizations, a few of them, as well as our professional affiliations that we work with. So I'll start off with some background on where our prior authorization initiative started. WEDI, in collaboration with the Cooperative Exchange, conducted a national survey of health plans and clearinghouses in 2015 as part of our NCVH testimony along with WEDI. The survey measured the adoption, use, and impact of standards, code sets, identifiers, and operating rules, and some of the associated challenges, barriers, and opportunities. So according to the survey results, of the 17 clearinghouses that responded to the survey, only 40% of them supported the 278 transaction. Of those that did support the prior authorization transaction, only 20% of them received the prior authorization information electronically. Most providers were using the clearinghouse's web portal. The inability of payers to provide real-time or timely determinations contributes to the lack of provider requests for this transaction, and the low adoption rate and the expected value of this transaction has not been realized, warranting further research. So some of the barriers that was identified as part of our survey, in addition to our membership calls and some of the collaborations that we've done along with WEDI, the PAG, the WEDI PAG, and some other organizations that we've worked with, included the granularity of the content of the X12 278 response does not meet the business needs, resulting in alternative methodologies for verification, the phone, the web, the fax. I will say, too, the fact that it is really easy just to find an alternative solution out there. It's one of the transactions that has an easy way to go solve that problem some other way, along with the eligibility transaction, and providers, obviously are taking advantage of that. Web portals and the other HIPAA-compliant alternative technology data exchange are more effective and provide all the necessary and useful information compared to the adopted transaction standards. I'll give you a great example of this. When researching with some of our durable medical equipment providers, some of the payers' websites have a list of every single supply or equipment that requires authorizations, but that information is not available when they try to run the eligibility request, so they have to go to that web portal to get that information. Lack of support for procedure code-specific prior authorization requirements in the eligibility response. So although the eligibility transaction does allow for procedure code lookups, that information isn't always supported by payers, and it results in those phone calls to request that information over the phone. Additionally, I will say that the eligibility transaction is one of those high churn rates for a lot of our members, and the reason for that, especially in some specialties that have a high prior authorization requirement with their line of business, if they're going to have to go to check prior authorization, they're going to check eligibility at the same time, and that causes a lot of the churn rate in those product lines. Some inquiries require responses that are not able to be processed for approval in an automated real-time fashion due to the need for medical review, that medical information. And attachments are not often required or supported electronically, so that's a barrier into being able to close that end-to-end gap. Additionally, it requires the breaking of the workflow where there's a manual effort that has to be done in order to complete that authorization request. There's limited vendor support for this transaction. Not only did we find that our own clearinghouse members, a lot of them don't support the transactions. The vendors, a lot of them don't support the transaction as well. And every health plan has their own format or criteria or forms. Some of them require faxes is the only way to be able to submit that information. They have their own proprietary forms that have to be filled out, specific criteria that has to be on there, and it's just extremely challenging for the provider community. A lack of accurate granular pharmacy formularies is also a challenge in the pharmacy industry. So some of the things that we feel like are critical success criteria in order to bridge some of these gaps and make the transaction beneficial and useful and really showing the value that's necessary, we feel are closing that gap and being able to ensure all the necessary electronic transaction components are in place to support that end-to-end automation. So the need for those specific prior authorization requirements in the eligibility response, and possibly looking at converging those two transactions or pieces of them, because right now, the eligibility transaction, you can request certain information, or some payers return prior authorization information in there, but then they have to go to somewhere else to complete the prior authorization process. And of course, there's a gap there. So really looking at a way to be able to find some common synergies and where it makes sense to possibly merge some of those features. Mandating the electronic transaction attachment standard. There is an attachment standard for a prior authorization request, and allowing for the 277 acknowledgement so that you can bridge that gap, understanding the transparency that the work has been done and that and it's all available within the single workflow. And then ensuring that the provider systems and vendors can support the Act 12278 transaction. Obviously, we need to be able to, we build it, we want to make sure that people are going to be able to come. Additional success criteria that we've identified is to evaluate the value of the current prior authorization transactions. Why are web portals so popular, and why are people using them in lieu of the standard? And what is the necessary information that we have to identify and bridge those gaps so that we can change the future versions or be able to include those features so that the X12 transaction would be the primary use of this information. Require that the X12278 standard transaction identify if an authorization is not needed or if it is approved or denied. Requires additional information and having the ability to send that additional information electronically and then provide an answer to those prior authorization requests. Additionally, payer portals or call centers, all that information that's in those systems are updated simultaneously along with the EDI standards so that the transactions can maintain the standardization across all lines of business and how those sources are being updated. Industry initiatives. So we've already talked a little bit about our joint WEDI Cooperative Exchange Industry Survey. That was very beneficial in the 2015 NCBHS testimonies, and we learned a lot of information from that survey. We have participated in multiple NCBHS testimonies for the operating rules, along with attachments and other administrative simplification requests. The Attachment Coalition, we're very, very, very excited and proud of this. Under the direction of the Cooperative Exchange, a coalition was formed with a representation from multiple stakeholders in healthcare, many on the line today. The AMA, vendors such as Epic and Cerner, clearinghouses, payers, and others. The purpose of that coalition was to show a united front with regards to the need for healthcare attachment standards. The coalition met on July 18th with the Division of National Standards, CMS, and it was extremely successful, and we are continuing to work with that organization for the attachment regulation. We have been conducting several attachment pilots to really show the value and be able to confirm that attachments can be sent electronically. It can be done, and it is working, and that there are people that are doing it. We've done several attachment educational webinars. Another one is coming up at WEDI next week, identifying those best practices and lessons learned from those pilots. We've done joint presentations at WEDI and the Cooperative Exchange on-site and monthly meetings to identify those barriers to reduce those eligibility phone calls. We've been working with payers and providers and with our clearinghouse organizations. And our members participate in CQH Core, X12, NCPDP, HL7, and the WEDI work groups and more regarding those prior authorization activities and standards development. So that is really it for us. Does anyone have any questions or anything that they would like to ask before we go on to the next presenter?
Yeah, this is Janice Vegas from Aetna. I'm very curious about the attachments and the methods that you're looking at. You said that, several groups are doing it. Are you looking strictly at 275? Are you looking at secure messaging? Or what methods were you exploring that you said were very successful?
The 275 transaction. We have some pilots with the 60/20 version. And we also are doing some proprietary mapping of some of those transactions as well.
Not only that, but actually there are members within the Cooperative Exchange that do the secure messaging transport mechanism, both using the data from HL7 as well as the 275, and then any other, like she's saying, proprietary. So to be honest with you, clearinghouses will move it any way we can. I mean, that's the definition of a clearinghouse. It would be lovely to do it all the same way, because that certainly provides for more controls, better security, better data. But until that's happening, clearinghouses will do it as best we can to meet the needs of both the provider and the payer. Does that help?
It does, Maureen. Are you finding a strong demand for the 275?
It's hit and miss. It depends on the ability of the sender. I mean, truly, that's it. The payers are, by and large, they're waiting. And what we see is if the provider can actually either work with us for us to create the 275 for them, or they can create the 275, then it'll happen. To say that it's a huge demand, not in Utah, but if you move to states like Minnesota where it's required, they're doing it, and by everybody. So, and I think that's really the point, if you look at the presentation, is it's kind of hit and miss, depending where you live, what your local laws might be, what kind of advancements in technology you have within your community. That's really what's what we're seeing as clearinghouses, because we have, providers in Minnesota that are working with payers that are located who knows where else, and that you would have to move. So clearinghouses are all over the board because all of the clearinghouses, as far as I know, are national, and so we've got to just meet those needs. And it would be lovely if we could get this and consolidate it to the 275. But until that's done, it's really us working together as a community to make it happen.
Yeah, and I will say, too, that, part of, like Doreen said, what a clearinghouse, the value add that we really provide is being able to work with any provider, whether they're low-tech, high-tech, or no-tech, and being able to solve that problem for them and transport that information however the payer wants it and in whatever required format that they need. So it really is agnostic to the provider of how it's being done, just that they can provide the information to us however they can give it.
Is there any other questions for Crystal, Doreen, anything else about the Cooperative Exchange? If not, Janice, are you next?
I believe that I am, Charles. And
Okay,
thank you, Crystal. It almost feels like so many of the same things that we're hearing. So, Heather, you're going to present the slides, correct, for me? I'm having some system issues.
Yeah, Charles, can you share my screen? I have Janice's slides for her.
Yes, I just changed presenter to Heather, so let's see. Is it showing? Yes. Mm-hmm.
Awesome. Janice, tell me what to do. Cool, thanks.
All right. All right, Heather, great. If you could just go to the next slide. So origin and purpose, really, the WEDI Prior Authorization Work Group was created in 2016, early 2016. And the real purpose was to identify the challenges submitters of the HIPAA-mandated X217, 278 prior auth transaction were experiencing, and why was it underutilized. So it was built, but nobody was coming, or it was not a vast majority of people that were coming to use it. So the work that the Prior Auth Work Group was looking to do is to really identify what those challenges are, and then look to find resolution or to alleviate those challenges in some way so that we could increase the transaction usage. And our original plan was really to work with the education committee, but to identify those challenges and send them over. But since we were told, go ahead, go forward and try and find a resolution. So our initial activity was really a survey back in early 2016 to understand where we were. So we were hearing a lot of anecdotal references that it's very underused, and we wanted to say, is this true? So we sent out a survey, and we received 134 responses, and about 65 of them were full. So it's not a great amount of responses, but I guess what we saw was that there was a lot of consistency in the responses. And the short answer to the question of, is the 278 being used, prior authorization being used, or was it underutilized? The answer is a definite yes. It really is being underutilized. And I think, as Crystal pointed out, there was a lot of, I guess you can consider it finger pointing as to, to why it's not being used. Nobody's asking for it. If I would send it, my payer can't accept it. So there was, a variety of reasons given as to why there was really not a large acceptance or, calling for the 217. So that was, again, part of our listening session back in Utah in May of 2017. And so Heather, if you can go to the next slide. So really, who is the WEDI Prior Auth Council? And the answer is we have approximately, over 100 people that are signed up to attend. On a general basis, we have 40 plus attendees. The good news is, and the bad news is that there's a mix of people that attend. Those 40 people really aren't consistent all the time, although there are some key persons that attend pretty much every session. But we get a good representation in a mix of submitters, transaction submitters, including providers, provider offices, facilities, and labs. Labs have a pretty large voice in our sessions. The vendors, the aggregators that send them over, and the value adds. A lot of what Crystal was talking about, they will transform whatever the submitter has available. And, of course, payers. So we have a mix of government and commercial payers. Growing sense of understanding, it's pretty interesting from when we first started, when the consensus pretty much was, this is what I need, So you almost had that triangular three-way split. You had the providers, maybe the vendors, and the payers. And what's pretty interesting is we're seeing a convergence of, who's really at the end of this, and that's the person seeking care. So how can we best really work to get this transaction to really suit the needs of everyone? Acceptance of the standards and items outside of that, as well as HL7's secure messaging. Heather, if you can go to the next slide. Okay. So when we first started, one of the challenges that we really had was, the 278 is so expansive on what it takes in, and there's the prior auth, the request, there's the notification transaction, there's the inquiry, is it referrals, is it pre-certs, and it was quite overwhelming. So we tried to limit what we would cover, at least initially, as part of what we were going to tackle. So we wanted to limit the scope to medical prior auth. So what we took as out of scope was pharmacy prior auth. They have NCPDP format that many are using. So we decided to limit it. Now, there is a pharmacy aspect of prior auth that is covered under medical, and so those would be included, but in general, pharmacy prior auth under the pharmacy benefit would be excluded from our discussions initially. Also, dental, there was some interest to use the 278, but in general, most are using the 837. And from a meeting we had just several weeks ago, they're pretty happy using their determination of benefits, which includes a lot of financial information in addition. So for now, at least, we're going to put that on the side. Also, eliminating referrals. We pulled together a whole document on different definitions, and not looking to get into that here, but really considering those of a referral, something more of a transaction of an administrative nature, not a prior authorization that really requires a review of that service, but more or less so-and-so will be going to, a specialist for some review. So we eliminated that from our scope initially as well. And attachments, there's a work group that works with attachments, and, that's their specialty. We're looking to work with them and embrace that because, as Crystal walked through in her presentation, it's no surprise, attachments is a very critical piece of, the acceptance people were saying, if the transaction, the pre-cert transaction, would go start to finish and there was no interruption in the flow, this would be great. So we were looking at the main reasons why the prior authorization is interrupted. Why does that electronic flow stop and need to be picked up again? So many reasons for that penned response, that interruption to the electronic flow is the need for additional information. Definitely something that needs to be addressed as part of attachments. Review by a third party, transactions that need, based on different relationships, needs to be forwarded to an additional party for review. So this pre-cert gets sent to a payer, but that payer has a relationship with someone else, and so that needs to be forwarded on. And what the group is really looking forward to do is saying, let's not stop that flow. Let's get that to be forwarded on. And another one was also the request submitting is we're waiting on a response. So that prior auth gets submitted. It does need additional information, but before that the actual response goes back, there is some type of a delay. Let's be honest, the prior auth can be a complex transaction. It requires input far greater than, if you're just doing an eligibility check and you want to know, who's the member and what's their coverage. You've got member information, all sorts of providers admitting and attending facilities, procedure codes, diagnosis codes, and any one of those, might be the cause of stopping the flow of a prior authorization. Heather, if you could go to the next slide for me. So what the WEDI prior authorization work group is working on right now is really 5 barriers, items that the group is saying, these are the reasons that we find prior authorization submissions challenging. And guiding principles, something to help along the way to improve that. So I'm going to highlight the 2 that I guess we've had success on out of the 9 so far. And the first one really is to talk about delegation. And that is when, a health plan really works with a third party and they, have a different group processing transactions on their behalf. So this issue was raised back in Utah at our first, when the WEDI Prior Authorization Council was first created, and at our first session back in May of 2016. And really the challenge is to delay that, when there's a pending response and maybe a day or 2 passes before somebody calls back and says, you really need to send this off to a different group for review. So the long-term goal that the group has come up with is really that if a health plan should have an arrangement with a third party, looking for that, and it comes to the payer, that payer could pass that transaction on to the responsible party. And to do that, we were looking at some of the ways to notify the original submitter. So we worked with X12, and they found a code, an HR1 code, a decision code that says that it acknowledges receipt. So it's a code that's available for other transactions, and we ask that they include that in the 278, so that if a transaction came in, was sent to the payer, it needs to go to a third party, the response could be acknowledges receipt instead of saying that, service is denied or something. And then including the information with TRO 3 of OB. So it's saying it's really the responsibility, and it's being forwarded to this third-party organization. And in this instance, the request would be that the name of the organization, the URL, and the phone number be included. In addition, a short-term solution to make sure that we take delays out of this, and I think everybody's looking to eliminate those delays from original submission, would be that if a submission comes in to a payer, needs to go to a third party, that they could say that it's not certified, and the certification is the responsibility of an external group, and again, including the information for that third-party organization. Heather, if you can go to the next slide for me, please. Okay. Sorry, a little system delay here. Okay. One of the other barriers and guiding principles that we were able to make some headway with was obtaining statuses on pending transactions. And some of the persons on our group said, I submit this, and, it's just my request is sitting there, and I'm waiting for a response. And I don't, I'm not getting it as in a timely way that I would like it. So how can I go and find out more about the status of this transaction? So what we're able to do is promote, one thing is to really promote the use of the 215 inquiry transaction. And I think everybody was saying, this was a great idea. It was put the ability in their hands of when they could do that inquiry, 24/7, whatever's available in the system, no phone calls would be needed. But in order to help that along, once that transaction is submitted, we've looked forward to including two decision reason codes, which were approved by X12 and will be included for the 70/30 guide. And one of them is the initial utilization review is in progress, and an escalated utilization review is in progress. So, it'll show a progression. Somebody will know not only was this submitted, but it's actually being reviewed, or, it was initially reviewed and it's been escalated for additional review. So they would be able to, if they did an inquiry, find out where this transaction is in the process. And the other is share the final decision when possible. So we're hearing that, I submit my transaction. Obviously, there's a variety of ways that people get their response. But what the request is when I submit my transaction, if no additional information is required, instead of pending, can I please get back a response saying no action required? So in those instances where that information is available, we would say, okay, no additional information is required. Basically, no pre-search required. These other ones as well. So if something's certified in total instead of pending, certified partial or not certified. So basically, the group is saying that what they're seeing is many responses as they pended, but they're looking to kind of get a shortcut and really get more right into the information that they're looking for. Heather, if you could go to the next slide for me, please. Okay. Well, I'm going to go into a little bit more, some about the other barriers. Now, I went into the two that we were able to get some additional codes included in the implementation guides for use, and that we feel that would be helpful. But, there's really 7 other barriers that the group is kicking around that we're looking for guiding principles to do. Not all may result in a guiding principle. What's really interesting is, and I think Crystal mentioned this as well, is, the question about prior authorization and the challenges begins well before the transaction is submitted, and that is, do I need a prior authorization? Now, the companion guides for 278 are pretty clear, that that's not the purpose of this guide. And I heard Crystal also mention, well, this may be something that the real-time eligibility transaction could return that information, so we would know, do I require a prior authorization? But as far as a shortcut, I don't know if there's a shortcut. We don't know. Maybe the answer to how you determine if a prior authorization is needed or not is to submit that prior authorization and find out from there. So another one is really, should there be a consistent way to find out, if prior authorization is necessary? People have different things online. So there's so many different approaches, really looking to see, should there be a consistent approach to where you can go to find out. Let's see. Again, there's a general agreement that the prior authorization should not result in delays. So really trying to get the response back as soon as we can to the submitter. In general, we're looking to have a final draft of the guiding principles that we're working toward by May 2018. Again, we're working on, we had 9 barriers and guiding principles that we're hoping to pull. We have 2 of those so far. The other 7 we're still working on. The other thing I guess we're hearing is offices tend to go with the guidelines of the most strict payers. So, if there's office turnover, that doesn't even flow down. So we find that, does the office staff have time to look up for each individual payer what there is, what the guidelines are? And getting concerns with approval for a specific procedure code has been raised. But what if the procedure that's actually done goes a little bit different from that original procedure code? So what will be covered? So as far as financial responsibility, just perhaps another concern. Something that might be able to be covered in the update transaction. So looking into that as well. And the slide that Heather's on is really the documentation that we've been working on, and one is the issue brief, and it's really the definitions. I can't tell you how much time we spent on, really what is a pre-cert and what is a referral. So really that document, which would be basically a supplement to the guiding principles white paper that we're working on, 2 of the items that we presented today, another 7 that we're working through for, discussion on should there be a guiding principle or not. Looking forward really hopefully to meeting with X12 and HL7 in January in Portland to get some additional information and their thoughts. They've been very helpful on getting us additional codes available for use. So really thanking them for that assistance. I think Bruce Delphi is on the phone from that committee today, so appreciate that and look forward to having a great success back in January for the 2 to 9 other barriers and guiding principle solutions. Okay, Heather, if you can go to the next slide. Okay. So anybody have any questions or comments?
Janet, this is Charles. Let me just comment on one thing. First of all, great presentation, and you and Heather are great joint presenters. I wanted to make sure that everyone understood that what you're presenting is the WEDI prior authorization work group that the work group is doing. It also, there were a couple of times that Janice also mentioned the council, and Janice sits on our prior authorization council representing the WEDI prior authorization work group. Heather also sits on the council representing the AMA. So they wear dual hats. There's a lot of interconnection here. So just wanted to point that out. And then is there any questions that we would want on behalf of the WEDI prior authorization work group? Okay. Sounds like you covered everything. And again, I think I heard one other person join us. Is there anyone that I haven't recognized that may have joined us while we were talking?
Hi, yes, sorry, I didn't want to interrupt. This is Diane Frey.
Thank you, Diane, for joining us. And and welcome. We are, and next, we have, first of all, make sure that we get the slides so we can share with everyone. Then what I want to do is turn the attention, if everyone is okay, I'm going to ask AHIP and DCPSA, who will now discuss the initiatives and efforts that they're covering. And I think that maybe, Kate, I'll ask you to make sure you introduce the folks that are going to be on the phone.
Sure. Thank you, Charles. This is Kate Berry, and hello, everyone. And on to Chaudhry from the Blue Cross Blue Shield Association joined us here in the AHIP office. I also have Rashi Venkatamaran and Kristen Stewart from AHIP who are gathered here. So we appreciate the opportunity to chat with you. And Anshu and I are going to sort of tag team our presentation because we share many, many members and I think are in very close alignment in terms of, our perspectives and work on prior authorization and medical management more broadly. So maybe just to kick it off, to introduce America's Health Insurance Plans very briefly, we're a national association and our members provide coverage for health and related services. We're very much committed to market-based solutions, public-private partnerships, and efforts to improve the affordability, value, access, and well-being for consumers. Some of our sort of key vision elements include promoting consumer choice and market competition, simplifying the experience for individuals and families, supporting, as I said, constructive partnerships with all levels of government, partnering with providers on the journey from volume to value, addressing chronic disease and the social factors that impact health, pursuing the promise of clinical innovations while ensuring value, and also harnessing data and technology to further drive quality, efficiency, and consumer satisfaction. So, you want to do an intro?
Yeah, sure. Thanks, Kate. Blue Cross Blue Shield Association, we represent the 36 individual Blue Cross Blue Shield companies across the country. Collectively, our plans cover 106 Americans, and we have 96% of hospitals and 93% of doctors are in our network. We have over 74 million members covered through group coverage, and we are in every zip code across the country.
All right, and so this is Kate again, and I think I see on the screen we we wanted to share, an issue brief that we've put together on medical management that's available on our website. And really the purpose of this issue brief is to sort of describe the value of medical management in promoting access to safe, appropriate, and cost-effective care. So really, while we certainly recognize, that prior authorization, can be burdensome, and I really appreciate the previous presentations in particular. While I didn't understand all the nuances, I will say that, you did a wonderful job of highlighting how complex this process really is in terms of all the different types of information that need to flow between many, many different stakeholders. So I think, just even understanding kind of all the different types of information, the players involved, and some of which are standardized and some of which are not, and kind of all the potential ways that, that flow of information and those processes can find some bumps along the way. I think we really just want to emphasize that medical management is, in fact, an important process to improve care, reduce costs for patients, and really try to help ensure that care is delivered in a manner consistent with evidence-based practices. And the value of medical management has certainly been recognized by the private sector, employers, and health plans, as well as in the public sector, through Medicare and other programs. So, just to further highlight, there's plenty of reports out there that show how there is wide variation in practice, and that care isn't always delivered based on the best evidence available. And so these tools can help protect patient safety, help to support affordability, and to ensure that people are not getting low-value care, but they're getting the best value care possible. So I just want to highlight some of the key themes in this, in this issue brief for you, but I won't belabor that since it'll be made available to you. Just one or two examples to highlight the importance of kind of the variation in care and how sometimes there's conflicting evidence. I mean, there's just a few examples, some in the behavioral health arena that include treatment for depression that is often not necessarily related to screening for the condition. So there's a 2016 study, for example, that looked at over 46,000 adults who screened positively for depression, and yet only a small percentage, roughly 30%, received treatment for that condition. And conversely, looking at a broader population of people, adults treated for depression, only about 30% had screened positively for depression. So that's just one example. I think another, just to highlight, would be how, I think there's lots of evidence to show that, combined concomitant prescribing of prescription opioids and benzodiazepines can be extremely dangerous for patients, and yet roughly 40 to 50% of patients who are prescribed opioids are also prescribed benzodiazepines. So those are just a couple of examples to show, that we do have some challenges in terms of, variation in practice. So Anshu, I think it's going to just touch on, and we both of our associations went through a process, as everyone knows, and Heather's on the phone and maybe Rob as well, that early this year, AMA provided leadership and a provider coalition and others to come out with the 21 principles to reform prior authorization, and both of us kind of engaged with our members to review those and think about the implications. So, Anshu, you want to
Yeah, sure. Thanks, Kate. And so I think you're all familiar with the principles that were released earlier this year, and following the release of the principles, as Kate mentioned, both of our organizations went through a process with our members to go through the principles and try to get an understanding of where our member plans stood on which ones they potentially agreed with, that they felt that, this is definitely something that needs to be addressed. What were some areas that maybe there was some agreement, but then administrative issues that maybe potentially could be a barrier to why the practice isn't sort of working ideally today, and then whether or not there were areas that maybe we weren't necessarily on the same page on as the coalition because of certain perspectives that we had, and maybe it was, there was a need to talk things through on where there was an agreement. And then on our, speaking from the Blue Cross Blue Shield side of things, I think by and large there were several areas where we did find that there was some agreement. The clinical validity principles that were listed in the document, I think for all of the principles that were listed there, our plans felt that, either this is already happening today or it's something that should definitely be happening. Transparency and fairness, I think in those there was a mix of, there was agreement, but then in some cases as well, there may have been some operational challenges which may have prevented some of the barriers as far as why things aren't working that way today, and plans were committed to discussing that further with the provider community. And then I think also the alternatives and exemptions section as well of the principles is where there was some agreement, but then maybe there was a mix, but there's a couple things there that potentially there were challenges administratively or outside of plan ability to directly impact. That is why maybe there's some confusion today. There were two areas where there was a little bit less agreement, and I think this is more because there may be barriers in place and sort of challenges when you look at medical policy versus covered benefits. And as we work with many employer accounts, a lot of time in the way that benefits are administered, sometimes there are challenges in place where we're not always able to do the things that the principles were calling for, or there may just be some additional challenges there. And so continuity of care was one where we didn't necessarily agree with all the, there may have already been federal requirements in place, and plans were abiding by those. And so there wasn't a complete agreement between what the principals were asking for and what plans are already doing. And then also timely access and administrative efficiency. I think this is another one where we felt that there was some opportunities to work more effectively together with the provider community, but some of the requirements or some of what the principles were outlining around determinations around medical policy and prior authorization in some of the appeals. I think plans felt that either they were already doing this or there were challenges in place for doing what was being recommended through the principles. And so, but I think where what the whole exercise was able to lead to was our plans individually taking a closer look at their own policies and seeing what specifically can they improve on their own. What are some things that they think that they might be doing well today, but clearly they're not communicating effectively with providers. And so, how can we improve that process? And following this exercise that we went through earlier this year, we, along with AHIP and the AMA and several other health plans and clinical stakeholders, started participating in a prior authorization work group, looking at ways that we could sort of open the lines of communication and get a better understanding of, not necessarily related to the principles directly, but kind of explaining to each other what some of the barriers were, what some of the opportunities were to try to improve the process, and where are some each plan sets their own policy decisions in the Blue Cross Blue Shield system. So to me, at the association level, we're not able to necessarily dictate how our plans would operate. They all have been closely engaged in this exercise, as well as we're keeping the rest of our Blue plans informed on the work of the prior authorization workers that Kate and Roz and Heather and others have been participating, leading, and so that we continue to keep this effort moving down the road.
Yes, so I would just add, I mean, I think one thing that has really impressed me in working with the clinical leaders at with our members is, the level of engagement in this process, as Anshu described, in terms of both kind of engaging to really review these principles and deeply think about, what currently works and where there might be opportunities for improvement. So I think, the plans really, they do work hard to streamline these processes and, as much as possible, recognizing that these tools are important to have in place. But I do think there is, it's important to note that, this process is challenging for everyone that it touches, consumers, providers, as well as health plans to, manage these processes and really do review on a regular basis kind of where, what processes need to be in place and how those should be refined over time. So I do want to emphasize that, and then just reiterate that, we are engaged with the provider community, led with AMA, and are very encouraged by the collaborative dialogue that we've been able to have over the course of the last several months together to both better understand each other's point of view and to, kind of get into fairly detailed discussions about, where the pain points are and where the opportunities for improvement are as well. So I don't want to go into too much detail, but I want to touch on kind of one of the categories that's very important that others have been talking about already, which we've had a fair amount of discussion about, both individually with our members as well as in collaboration with the broader provider community, and that is, automating this process. And, and automation, could improve both the efficiency, but also we think, is an important part of transparency and communications. And so, we think this is in particular an area where, there's no one stakeholder who can step up and make it happen. And again, I think the other speakers have talked about, some of the efforts and some of the complexities around, what's already standardized in terms of the exchange transactions, what's not standardized, and then, how do you move forward with adoption of those things that are standardized, as well as, move the ball forward in standardizing other transactions, and so you can have multiple phases. But I think that's an important big area where, it's going to require lots of stakeholders to get involved and even advocacy at the federal level and others, just to drive that whole process forward. So I think I'll stop there. And do you have anything else? I think we've covered, so we'll just stop there and, welcome Rob and Heather to comment on kind of our collaborative process if you would like to, and or open it up for questions.
This is it's great to, from my perspective, to hear how a variety of us are all working together towards finding the right solutions, and it's great that we have a lot of groups working side by side that are part of the council here. It's also other groups, and we certainly will have some more presentations on December 4th, next Monday. But is there any questions for either Anshu, Kate, Heather, Rob Otten is also on. Anyone, any discussions about their efforts and any pieces of the presentation? Well, and I do want to recognize anyone else. I think Tim McMullen is on. He's been on for a while. He emailed me, so welcome, Tim. Is there anyone else that I haven't recognized? Let me know that you're also on. I do want to, again, is there any questions overall, any comments about the effort? And again, thanking everyone for your efforts today. And we do have, I think, around 4 presentations for next Monday. We're going to hear from CAQH Core. Bob is going to present. We're going to hear from NCPDT, X12, and I think MGMA as well. But in any event, any questions for any of us today? Any comments, or shall we give you 45 minutes back on your calendar? Don't hear any objections to that. With that, as a reminder, we're going to be on the face-to-face part. We'll be in Reston, Virginia at the Hyatt Regency Reston. We'll be starting, I think, around noon, and I'm not certain if the HL7 representative will be able to join us, but in any event, he will bring a lot of good, Walter not only has the NCVHS experience, certainly from Kaiser as well, and we look forward to his participation. And we're going to be, if you're driving in or coming in, it will be in the Lake Fairfax room, and I will send all of that information so that for those that are going to be joining us remotely, you will have the call-in information. With that, I want to, on behalf of John Kelly, and hopefully I want to say how enthused we are with the responses, and we look forward to the remaining presentations on next Monday. And I believe that it's all timely with the activities of NCDHS in the very near future. With that, thank you again for joining us, and please, for those who have send me your slides so that I can send them out to everyone to everyone who's on and who hasn't been on. So thank you again, and